And now it's time for Through the Eyes of Dr. Mittleman, brought to you by Mittleman Eye with 2 locations, West Palm Beach and Jupiter. And now here are your hosts, Jill Schweitzer and Dr. David Mittleman.
Good Saturday morning. Thanks so much for waking up with us and Through the Eyes of Dr. Mittleman.
Well, thanks for having me again, Jill. It's wonderful to be here yet again on another early Saturday morning.
Well, it's always an adventure on the radio for me especially, and I know so many of our listeners, because you never know where in the world you are and what in the world you're going to talk about. And today, the topic is Tales from Residency. So first tell us, where did you do your residency?
So I did my residency at a place called Wills Eye Hospital in Philadelphia. It's probably the top hospital for training ophthalmologists, surgeons, not necessarily for training heads of departments or Nobel Prize winners in ophthalmology, but for actual surgeons and clinicians. It's a great place. This is where I wanted to be. It's also a fun place. They have black tie balls, and you're told when you interview there, you must have a tuxedo because there are 4 black tie balls a year. It's one of the largest residencies, so I had 10 other classmates. I actually had 11, but 1 dropped out at the last minute, which is entirely unheard of in ophthalmology. It's fun. I don't love Philadelphia, but I did love Wills Eye and my colleagues.
Wow. So, I've gotten a little taste of some of the stories from when you were in medical school and the trials and tribulations, but give us some tales now from residency.
So when you become a resident, you're starting in a field that you may have some knowledge about. You may have done some research or some papers in that field, but chances are you really haven't delved into it in detail. For ophthalmology, many medical schools don't even have an ophthalmology program. They spend a day in a lecture hall. I had 10 days of mandatory ophthalmology in medical school, and then I did some electives. But when you get to residency, I had no idea what I was doing. At Wills, they do it a very nice way. You have 3 weeks of lectures before you actually start to see patients. So when you start to see patients, you think you know a lot. You really don't. But you start taking call immediately. Wills Eye Hospital is the eye emergency room for the entire Philadelphia area, 5 million people. So if you called your local ophthalmologist and you said, "Hi, this is Dr. Richmond. Please leave a message. If it's an emergency, go immediately to the Wills Eye Hospital emergency room." And so there were people coming in at all hours of the day. It was my first night on call. I had been in 3 days of lecture. I'll never forget it. I thought, okay, it's eyes. How bad could it be? And at about 2 in the morning, I get a call. There were little rooms in the hospital from the nurse in charge of the emergency room. "Dr. Mittleman, we have a patient down here that needs to be seen." And I'm thinking, I've never seen an ophthalmology patient before. But I come down, I see the patient, and the patient's eye is full of blood. Full of blood. It's bright red. The lining of the eye is swollen with blood. And I'm looking at this thinking, this is disgusting. This is horrible. This woman is going to bleed out of her eye. What's going on here? I had no idea. And that's the same reaction that patients who have this get when they come in, when they call us up. "My eye is full of blood. What's happening? I don't understand." So I don't know what this is. I've never seen it before. I call up my third year, a gentleman named Paul Raskowskis, who is a retina surgeon over in the Tampa area. And he's a nice guy. He's very good at what he does. But it was 2 in the morning. He was in his last year, and he said, "Mittleman, just take care of it." Paul, I don't know how to take care of it. I don't know what to do. I've never seen this before. I've never been on call. I've never seen a patient. "Mittleman, I'm sleeping. It's 2 a.m. I'm like, "Paul, please, I don't know what to do." So meanwhile, there's this patient there with this huge red eye. It looked like she had an egg tomato coming out of her eyeball socket. Paul comes down, goes into the emergency waiting area with me to pick up this patient who's in the waiting room. And as we're walking in, the woman's saying, "My eye is red." And Paul says, "It's okay. I'm going to tell you what you have." And we walk into the exam room, and Paul says, as the woman starts to sit down, "Don't bother sitting down. You won't be here that long." And the patient and I looked at Paul with just amazement in our eyes. And he looks at her and says, "You have a broken blood vessel. Don't take any Advil for a couple of days. Go home. I'm going back to bed."
Oh, my God.
The patient and I looked at each other and didn't know what to do. And Paul walked out of the room.
So that was that.
And that's it. And sure enough, when someone breaks a blood vessel, you don't do anything. There's nothing to do. But I didn't know that. I didn't know what it was. And Paul went back to bed. And in the morning, I said, "Paul, tell me a little more about this." And he looked at me and said, "About what? There's nothing to tell. It's a broken blood vessel." End of story.
Well, I've had that experience where I rubbed my eyes too hard while I was washing my face, and I woke up in the morning one time, and the inner corner of my eye was just bright red. I'd broken.
It's scary.
It is
very scary for
yeah.
a patient and for a doctor who's never seen this before. I still get calls from primary care doctors or the local emergency rooms for someone that has a subconjunctival hemorrhage. That's what it's called, under conjunctiva, the lining of the eye, hemorrhage. And when you say hemorrhage to someone, "Oh, I need to be seen right away," and it's not really. It's a couple of drops of blood. It's like if you cut yourself and a drop of blood goes into the toilet bowl turns red from 2 drops of blood. Couple of drops of blood under the lining of the eye make it bright red.
All right. Well, that was your first night on call. How about your first day in the clinic?
I tell this story a lot. It's still horrifying to me. So 3 weeks of training have gone by. I've gone to lecture. I think I know just about all there is to know in ophthalmology. And of course, that's not true. The ophthalmology textbooks, they're not really in writing anymore, but when they were, it's 6 volumes, and it's about 1,500 pages per volume of all the normal things, the strange things, and the 1 in a million things. And you have to know all of it, at least at the outset. At this point now, if somebody has something strange, I know what it is, but I put them on the Mittleman rocket to go to the subspecialist that knows what to do. My first day in the clinic. And they give you 4 patients, 2 in the morning and 2 in the afternoon. 2 patients in the morning, that is about 2 hours per patient. And we're still running an hour or 2 behind because we have no idea what we're doing. We've been taught how to do an eye exam. The clinic is packed. There are 2 small rooms. There are people in wheelchairs, people with walkers, and it's in downtown Philadelphia. Some of these people aren't getting health care anywhere else, but at Will's Eye, it was for free in the emergency room. So I get a patient. She was a rather obese young black woman. It's important that she was obese, and it's important that she was black. And there were notes in the chart that she wasn't fully compos mentis. She was a little off. And her chief complaint was, "My eye pops out of my head." She was on some mental health drugs, and she was living in an assisted living facility, so she was taking her medications. But she said to me, "My eye pops out of my head." And I take the history. When does it pop out? It pops out at any time. And what do? Well, I push it back in. They said, "Is your vision affected by this?" "No, but I don't like it popping out." And this has been the chief complaint for the last 7 years. So I look at her, I write the history down. This is all on paper with pen. There's no electronic records way back when. And after I look at the front of the eye in what's called a slit lamp, I lay her back to do a fundus exam. Now, a fundus exam, you put this funny hat on your head called an indirect ophthalmoscope. You hold a 3-inch magnifying glass in your hand, and you look at the eye, and you have the patient look up, down, left, right. Sometimes the patients squeeze, so you have to hold their eyelids open. So this large woman is now lying back, and she's squeezing her eyes. I hold her eyelids open, and sure enough, her eyeball pops out of her head.
Oh, my God.
Onto her cheek. She's looking right at her upper lip, and I look at her, and it is a Home Alone moment. I scream, "Ah!" And she looks at me screaming, and she screams, "Ah!" And I scream back, "Ah!" We're screaming at each other. I run out of the clinic. I trip over a walker. I trip over somebody's crutches. I fall flat on my face. I get myself up, run to the other room. Third year. because I don't know what I'm doing. And this eyeball, you can see the optic nerve between the eyelids. And I pull the guy back, the third year, who says, "What are you doing, Mittleman?" I come back and the eyeball's back in the head. And he says, "You are as crazy as this woman is. Are you sure you chose the right profession?" I'm like, I swear to God, her eyeball was on her cheek. As it turns out, some younger black women, and I guess older, have shallow eyeball sockets. She was nearsighted. She had extra optic nerve. She had extra fat around her eyeball because she was a little obese. And sure enough, the eyeball can pop out of the head.
Wow. Did not know that.
It was so scary. And as it turns out, the way to fix this, I actually got to do a case as a first year, which you never get to do. You sew the eyelids closed a little bit on the temporal side, on the ear side of the eye, so that the eyeball doesn't have enough room to pop out.
And there you have it.
Fixed.
Wow. That is wild. I've never heard of that. That's for sure. Only in a horror flick, where...
It was like a horror film. And I, of course, amplified it being a little expressive, running out of the clinic, tripping over everybody, screaming like a banshee.
Well, but you were responsible, and I get it. I mean, I think, what I learn a lot from you is that you have to be able to deal with stress in your line of work. You have to have a particular personality that can deal with these high-pressure, stressful situations.
And sometimes the situations are more stressful than they need to be. So the next story I want to tell was incredibly high stress for me. I had to keep my cool. So a woman walks into the emergency room with a sty, a chalazion. A chalazion is the clogged oil gland, and you have 30 to 40 on your upper lid and 30 to 40 on your lower lid. And when one gets clogged, it backs up. You get a bump on your lid, and sometimes they can be painful. The first line of treatment is warm compresses, massage, and some drops, but that doesn't always work, and you're left with a big bump. And a lot of people don't like this big bump. So you took them out in a small minor operating room in the emergency room as a first-year resident. It was really the only surgery you were allowed to do. It wasn't surgery. It was a minor procedure. So the professor, the attending, who taught us how to do this was a gentleman named Jack Jeffers. When you're young, your professors, your attendings, your teachers seem like towering figures that are scary and omnipotent and omniscient. Jack was that way. He was the ophthalmologist for the Philadelphia Eagles and for the Flyers and for whatever the basketball team is, I'm forgetting.
You don't ask me.
And he had a Super Bowl ring on because he was their team, the Eagles team ophthalmologist. He was a scary figure. He didn't speak much. He had a short buzz-cut hair. And to me, he was 7 feet tall, and he was probably no taller than I am, 5'9.5". Very stern. Taking a chalazion out is not a big deal. And yet, he found 2 10-page articles on how to do this. So everybody who does this, all 11 of us, get this article. And you read it, and you go in, and you have this patient who has no idea that this is the first time you're doing it. In these days, if I'm doing something for the first time, I tell the patient, this is the first time. I feel you have an obligation to tell someone. But in residency, at least back then, you did not tell them. So I'm sitting there with Jack. I take the Novocaine, the lidocaine actually, I inject the eyelid to numb it up. I put the little clamp on the eyelid. I flip it over. Good job, Dr. Mittleman. Good job, Dr. Mittleman. I take my knife. I incise the chalazion, and I take what's called a curette. A curette is like a spoon, actually invented at Will's. And you go and you scoop out everything. And Jack said to me, hold it like a pencil. Yes, Dr. Jeffers. I keep on curetting out. Hold it like a pencil. Yes, Dr. Jeffers. I keep on going. Hold it like a pencil. Yes, Dr. Jeffers, I understand. And he yells at me with some expletives while the patient is lying there that if I don't hold it like a pencil, he's going to walk out. Yes, Dr. Jeffers. So I continue to go. He stands up. He slams his pen down on the table, storms out of the room, and now I'm sitting there trying to finish up this Chalazion with nobody there to tell me what to do. I know what to do. I've read the book, but it doesn't matter. I'm in this person's eyelid, and I'm freaking out. And the nurse comes in and says, "It'll be all right, David." And I look at her and I'm like, and the patient's lying there. I said, "It's not going to be all right. I don't know what to do." This poor patient lying there with this man that screamed at me, storming out of the room. The nurse says, "Just finish up what you're doing. It's almost done. You're fine. It's beautiful." I finish up. I walk out, and Dr. Jeffers looks at me and says, with some more flowery words, essentially, "If I tell you to do something, you do it." I said, "But I did, Dr. Jeffers. I did exactly what you said." So he hands me a pencil, and he says, "Write your name." And he says, "Oh, you hold your pencil wrong." "You told me to hold it like a pencil. This is how I hold a pencil." So he made me write my name. This is how and David Mittleman, this is how I hold a pencil, the way he wanted me to hold a pencil. And I had to go home and write that. My name is David Mittleman. This is how I should hold a pencil 1,000 times and bring him back the 4 or 5 sheets of paper with it written over and over and over again. And so when I did more Chalazions with Dr. Jeffers, I held it like he wanted me to hold it. And when I go to the operating room, I hold things the way I want to hold them.
I was going to ask you, did that stick?
Never stuck except with Dr. Jeffers.
Okay.
And one of the things that is good for me is that because I hold a pencil and a pen improperly, I taught myself to write when I was three or four by tracing letters in the World Book Encyclopedia. I actually have better access to the eyeball.
See there? That goes back to one of our previous episodes where you said to honor your children, their wishes, the things that make them tick, the ways that they are attracted to things. It kind of goes to that.
It does. Similarly, if you were in Catholic school, and I'm not Catholic and I've never been to a Catholic school, but I have friends who have, if you were left-handed, they made you write with your right hand.
Oh, they'd smack you with the ruler first.
And that's just not conducive to good learning and good outcomes. You have to work with what you have.
Agreed. And we're all very, very different. We all have our talents and strengths. So, you're sort of famous in our area and probably beyond for cataract surgery. I know from the Northeast, the people that listen to Legends, they've come down here to get cataract surgery with Mittleman Eye. So what was your first when did you first delve into, no pun intended, cataract surgery?
So there are 2 stories that go along with my first cases. When you're in residency at Wills, you do these minor procedures. You do Chalazions, you do what we call Ditzels, just little skin tags and so forth your first year. You are not allowed to do cataracts in your first year. You do 8 cataracts your second year of residency, and then you do several hundred on your third year. It's ramping up. I think ramping up too slowly, but that's the rules.
That's you.
When I did my first year, you assist other doctors doing surgery and you watch them. It's a fascinating experience because at Wills there are at least 100 cataract surgeons. Remember, this is the entire Philadelphia area, and a lot of people want to say, "I'm on staff at Wills," and they come to Wills. So assisting means you squirt the cornea. You keep the cornea wet. You don't really do anything, but you get to watch the way other doctors do surgery. You actually learn more from the bad surgeons than you do from the good surgeons.
What not to do.
Correct. Well, that got him in trouble. I don't want to do that. So there was a young attending there, a gentleman named Adam Altman. I respect him greatly. He was a couple of years older than I am. He's still working in Philadelphia, and he's very well respected. I'm helping Adam. We're friends. He does the first case, and he does fine. He's a good surgeon. And he says, "Mittleman, how many of these have you done?" The answer was 0, but that's not the answer you give. At Wills, if you had done 0, you'd done a few. If you've done a few, you've done several. If you've done several, you're an expert. So I looked at him and I said, I've done a few. And he said, "Do you want to do the next case?" And I said, with fear, being buried as best I could. Yes, I'd love to do the next case, thinking I have no idea what I'm doing. But I've watched 6,000 cataract surgeries. I've practiced with saran wrap around my orange. I've done all the things you're supposed to do. So I sit down at the head of the bed, and I start to do the case, and I finish in about 14 minutes. This is many years ago. 14 minutes was incredibly fast back then.
What was the average?
Most of the surgeons at Wills were taking 30 minutes.
Okay.
I did mine of 14. And Adam looks at me and says, "Oh, you were being modest. You're a pro at this." And I said, "Well, thank you, Dr. Altman." And I didn't want to say I'd never done it before. I also didn't want to be kicked out of the program for doing something I wasn't, but I was offered this opportunity and I took it. He looked at me and said, "You want to do the next one?" And I'm thinking to myself, you don't want to tempt fate. But that's not what came out of my mouth. I said, "Of course I want to do the next one." So I did the next one, and I did it in 11 minutes. Now, these were not overly difficult cataracts, but Adam looked at me and said, "That's amazing. You're going to be a great surgeon." He says, "But I'm going to do the next one." Poor Adam. It could have happened to anybody. He did the next case. He had a complication, and he was in there for almost an hour. And I wanted to say, if you'd only let me do the last case, we would have been out in 10 minutes. So that was the first unofficial case. Everybody knew I did these cases. My first official case was not so wonderful. I was now a second year, and I was given a white cataract as my first case. Now, I hadn't done any cases. A white cataract is when your cataract, instead of being partially opaque, is totally white. And the techniques were a bit different. The machines were different. The microscopes were different. When you have a white cataract today, you stain the front of the cataract with something called vision blue so you can see what you're doing. It stains it a light blue. There was no vision blue. You couldn't see what you were doing. I was with a very well-known surgeon named Jim Cardy, and Jim was a wonderful man. He was a great teacher, and he was an amazing surgeon. He was one of the top surgeons at Wills, and I loved Jim. He was friendly and he was kind, and I have this white cataract that I never should have had. So I do the first steps. Very good, David. I do the next step. Very good, David. Now it comes time to take the cataract out, to do what we call the phacoemulsification. That's breaking the cataract up. Now, that was a relatively newer concept. Many doctors at Wills didn't know how to do it. This was 1990. They didn't start to teach this in Miami until the year 2000. It's 1990, and I'm doing this as a first-year resident. So I take my instrument, I bury it in the white cataract, and I can't get it out. And I can't get it out. And I said, "Jim," I was on first-name basis with Jim. He was that kind of friendly guy. I can't get this instrument out of the eye. I need help. I said, "Can we change places?" He says, "No, you're a good surgeon, I've heard." Well, I may be a good surgeon with normal cataracts. I've never done a cataract like this before. He says, "Just give it a little more gas. Step on the pedal and pull the instrument out of the eye." And I said, "No, Jim, I don't want to do it. I don't want to do that." And I'm sort of quaking with fear. Thank God I don't get a tremor. And I give it a little more gas. And instead of pulling it out, it goes right through the cataract, and the cataract starts to fall into the back of the eye. And I said, Jim, you need to take over." He says, No, go get it." Well, the first thing you learn in those first 3 weeks is do not get a cataract that's falling into the back of the eye. And he says, "No, Mittleman, go get it. That's what I would do." I said, "But they told me never do this." He says, "You're with me. I'm responsible. Go get that piece before it falls too far." So I take my instrument, and I go into the middle of the eye. I grab it. I pull it up. I suck it out. And he says, "See there, you're a good surgeon. I knew you could do it." Of course, the sweat is coming down the sides of my head. I put the lens in. I sew it up, because in those days you had to sew it up. And I was so freaked out by doing something that I was told never to do that I sewed in 14 diopters of astigmatism. So what's a diopter? If you have one diopter of astigmatism, your vision's blurry. I sewed in 14. We had to do stitches because I pulled the stitches so tight, I did not want this wound to leak. Person comes in the next day, all they could see pre-op was hand motion. Only if a hand was moving, they were 2200, the big E. I was crestfallen. They were thrilled. They were so thrilled. Dr. Mittleman, I can see you're a genius. And I'm thinking, if this is what a genius is.
You got a great career ahead of you.
And so over the next 3 months, I pulled the stitches out, and this woman wound up being better than 20/40 uncorrected.
Wow.
And to this day, I will always remember Jim Carty for telling me what to do. We'll talk about rules at another episode, but to occasionally break the rules.
Yes, case by case, right?
Yes.
That's what makes you so great, Dr. Mittleman. And I am sure you've got a gazillion stories. Can you give us one more, like, quick one? Because these are just, most of us have not walked your path. And not only as a doctor, but in all of your world travels, everything that you do. So one more quick one.
So I'll tell you a very quick story. Back in the day, it was expected that you did moonlighting at Wills. You moonlit in other ophthalmologists' offices from 6 in the evening until about 10 at night. And I went in, and I had a lot of jobs. I had no money. I had a lot of student loans to pay off. And I saw a patient with a PVD, a posterior vitreous detachment, which is when the jelly in the back of the eye pulls off the back of the eye. It's a common occurrence, happens to almost everybody later in life. And most of the time it's benign. You see some floaters, some flashes. It settles down. Occasionally, as the jelly pulls off, it tears the retina. And it can tear the retina so much that your retina can come off. You get a retinal detachment and you go blind. We all know as ophthalmologists that you can develop a tear anytime in the first month. Actually, even later than that, but the highest risk is the first month. So I see this patient with a new PVD. I don't see a tear. I spent 10 minutes looking at the back of the patient's eye because I did not want to get it wrong in a private practitioner's office, and there was nothing. I said, come back in a month. That was the guideline. I hear 3 weeks later that the patient had a detachment and was in the operating room in Wills on the day I was in the operating room, and I thought, oh my God, I missed this. They're going to kick me out of the program because you're always walking on eggshells. You have these world-famous attendings who write books, who lecture around the world, and there we are as residents, and we're very good. You don't get into ophthalmology unless you're good at what you do. And I said, they're going to kick me out. And so I saw the attending who I was moonlighting for a couple of weeks later, and he says, no, you didn't miss it. I saw them a week after you did, and I didn't see a tear either. They develop it in 3 weeks. And you realize in these stressful situations, remember reality. Remember the natural course of things. Because sometimes things happen and it's just not your fault, and you didn't miss it. But as a doctor, one of the lessons you learn is that you always blame yourself, and sometimes it's just not your fault. You didn't miss it. It wasn't there. When the patient comes in with saying their forehead tingles and there's nothing there and they have shingles, you've missed it. So always remember, look outside of yourself to see if there's other causes or other influencing factors.
Those are words of wisdom for all of us. They really are. I was just thinking something like that yesterday. But again, that's for another episode. It is always fascinating. I always learn something. And again, I know our listeners are tuning in to Through the Eyes of Dr. Mittleman on Saturdays at 8 a.m. And we'll be back here next week.
It'll be my pleasure. I love doing these shows and sharing stories.
Thank you for listening to Through the Eyes of Dr. Mittleman here on Legends Radio. You can tune in every Saturday morning at 8 a.m. for another edition, brought to you by Mittleman Eye, 561-500-2020 or mittlemaneye.com.